My name is Darla Reynolds. I'm the program manager of the Nuns Emergency Department here in Edmonton. I have no disclosures. I'm not that interesting. Here in Edmonton, we have a collaborative stroke program. So Edmonton Zone, along with the U of A, which is our comprehensive stroke center, and the Grey Nuns came on about 10 years ago as a stroke center. We have been working towards excellent door to needle times for the entire time that we've been a stroke center, and I can say that we had good times and good processes in place prior to QuiCR. I'm just going to walk through some of the processes that we did have that were working for us, which allowed us to build upon in post-QuiCR session September 29th. So we were getting really good pre-notification from EMS. They were voting in, and we had really good processes in place in order to distribute that fan out for information. So we would automatically have the charge nurse call the neurologist. We let the CO know, the ED physician. We let DI know, triage, the bedside nurse, and of course, lab. We're lucky enough in the excuse me, Grey Nuns Emergency Department to have dedicated lab services. So on arrival, the patient would be triaged, and we quickly determined in about 2011 that it was easier for us to sort of swarm the patient at triage and then have EMS take the patient directly down to CT. I think that this was because of our smaller footprint as a smaller site. We are a large community hospital, but we're certainly a little smaller than, say, the U of A. So we initiated that in about 2012. Often our neurologist would be in-house and in the department when the patient arrived, and he would assess the patient on arrival, and he would accompany down to CT. Once the patient had their scan, they came back to Emerge, where our nursing staff would then assess and begin IVs, that sort of thing, and we would then administer TPA. So post-QuiCR, we realized that there was a lot of opportunity to shave minutes off of our already established processes. And that's what we got busy doing as a zone program. Our post-QuiCR meeting in September, afterwards we convened as a zonal team with representation from ED, DI, stroke, and the medical teams. The discussion was facilitated by the Stroke Program Edmonton Zone and AHS Quality Initiative. So what we talked about was what processes can we streamline and standardize at both sites in Edmonton, and what can we learn from each other that we're already doing well. When we implement it, and then we talked about how we were going to roll out to our respective sites. So the next two slides are quite involved, but what they show, I think, is all of the processes that start from the time EMS picks up the patient to the time TPA is administered, and how everything needs to happen in parallels, not in series. And it also talks about the many steps that our patients need to go through to navigate often our quite complicated and varied system. So this is the process at the U of A. The clock starts at triage, ends with TPA administration. We've tried to standardize as many processes at both sites. However, it's not possible to standardize 100%. For example, our swarm at the Grey Nuns happens right outside of triage, and the swarm at the U of A needs to happen in APOD simply because of space constraints and how large their department is. So as a zone program, the U of A and the Grey Nuns hospitals, we decided to move forward with some new processes. So what we quickly determined was registering the patient as unknown using Edmonton software wasn't going to work. There was too many problems on the back end. And there was opportunity when EMS phoned us for pre-notification to pre-register the patient. So where that's possible, we do that. In lieu of that, what we try to do is we've made a standardized triage assessment. So we've allowed those triage nurses to feel confident in a simple line. It's acute stroke, time of onset, whatever that was, and vitals per EMS, straight to CT. So as I mentioned, the patient is swarmed at triage at the Grey Nuns and APOD in the U, at the U. And the bedside nurse now goes to CT with EMS and the TPA kit. So this is a big change for us at our hospital. And it was probably the one that the nurses struggled with the most, because in the past they had each other. We always doubled up on a stroke patient, so there was 2 of them. They could do their drug calculations and they could, start the infusion. It was kind of a buddy system. So they were feeling a little bit forlorn, and we heard that from them, and we tried to reassure them. And so what we've gone at the Grey Nuns, and I believe at the U of A too, is that we're empowering them to do the bolus in CT, and then because we have such close proximity from the CT scanner to our ED department, we bring them back and we start the infusion within 5 minutes. And I think that's made them feel quite comfortable. So this actually talks about our timestamps. We actually drilled down and took a look at what each point in the patient journey through the initial emergency visit looks like. So the clock starts when the patient arrives. So notification is made of the patient arrival, and that's that fan out that I spoke about. That's about a 2-minute process. The swarm that happens at triage or an APOD at the U is the rapid assessment of the patient by all the key stakeholders. So you've got triage, you've got the neurologist or the stroke fellow, you've got the bedside nurse, the emergency physician if they need to get involved. And we've given that about a 10-minute time. So there's certainly opportunity there that if it doesn't take 10 minutes, then they're off to CT quicker. EMS transport to CT, so that's physically EMS taking the patient to CT. Bedside nurse and attendants, that's a 4-minute process. And then CT scan to bolus, we're aiming for 10 minutes. This is a look at our TPA kit. We've streamlined this kit quite a bit. I know that the Foothills was gracious enough to send us a picture of what they had in their kit. But we decided that we've got really good access to our antiemetics and anti-seizure medication and any infusion lines and that sort of thing that we need. Either in DI or in the emergency department, we can call over for it really quickly. So in order to not overwhelm our nursing staff, we went with the basics in our kit. So it's just basically what you need to start a line, draw the labs off if they didn't get drawn off at the swarm, and our TPA, and of course, the patient care order set, which allows the nurse to do the calculations to mix it up and give it. This is actually going to go into a soft-sided, sort of cooler-like container. So as a manager, I'm a big believer of how you roll your processes out will dictate how successful they are with the frontline staff. And we all know it's the frontline staff where the rubber meets the road. We as educators and leaders and physicians can come up with the best processes there are. But unless we've got really good frontline understanding and confidence to use them in involvement, then they're not going to achieve the results that we want them to. So when we rolled this out, we used a couple modalities. We did a verbal. We have what's called a jump start in our department where the off-going charge nurse talks to the oncoming shift. So there's about 18 nurses, and this is our opportunity to talk about the shift, the acuity, things that are going on, but it also allows us to talk about new initiatives and rollouts that we're doing in our department. We also put out a written communique, and in it we borrowed from Dr. Hill. We had a couple sort of sensational taglines. We said, did you know that every minute your patient's having a stroke, the patient's losing 1.9 million neurons? And then we talked about 30% of the patients that we deem in ER as either mild or improving are either dead or severely disabled at discharge. So then we discussed what specifically we were going to tweak in our already well-established processes. We gave them CNE support. So we said from Monday to Friday during the time that the CNEs are in, that we would ask them to page them, and they could go down to CT with them, and they could be involved in the process, and they could support them. And then, of course, our frontline champions. When I was doing our door-to-needle time, I was reviewing them a few months back, and I was reviewing them for the year. What we do in Edmonton is we give out door-to-needle pins for those times that are under 50 minutes. So I compiled all the data, and I was looking at all the staff lists, and one name kept coming up. And it didn't matter if he was at charge or triage or bedside, this name kept coming up. It was the same nurse all the time, involved in all these cases. So I thought, well, what is this nurse doing specifically? So I called him to my office and we had a little chat. And this is a picture of Richard. Richard's with us today. Richard does not communicate this way. Richard is actually a very astute senior emergency nurse. He's very respected amongst his peers and medical colleagues, and he uses very clear communication. He's confident in his assessment and knowledge skills as a nurse. And what Richard does is he owns and drives the process. He understands the process, and he takes control. And he actually takes control even if he isn't charged, which is okay because he understands what the goal is here. And he has for quite some time. This isn't a new phenomenon for Richard. So Richard ensures that all the stakeholders have the right information. He actively manages the details. I said micromanage. They told me I couldn't say micromanage, so he actively manages the details. He anticipates problems and finds solutions quickly, and he closes the loop on communication. When I was investigating that phenomenal door-to-needle time that we recently had, it was either 8 or 12 minutes, we're not sure. That's really like splitting hairs in my mind, but so I punched into EDIS and I thought, well, I have to look into this because I hadn't heard about it. And up pops the triage record, and lo and behold, whose name is on the triage nurse, and it's Richard. The interesting thing about this case is that patient walked into our department. He was not brought in by EMS, was not brought in by EMS, she walked in. And what she sat down at the triage desk and told Richard was that she had hypertension, and she was having some problems with hypertension. Richard assessed her, quickly established in his own mind that this wasn't just hypertension, there was something else going on. So he stopped triaging her. He just had acute stroke symptoms. He sent the chart off to admitting. He took the patient to acute. He told the charge nurse, neurology was in the department. He told the doctors. He told lab. He phoned DI. And he orchestrated the bedside nurse getting there. The bedside nurse just grabbed the patient and took her down to CT. And CT cleared the scanner, got the patient on. So she's going down. She doesn't even have a line in. We haven't drawn her blood work yet. But she gets back. The nurse puts a line in her, and we give the TPA. So that's how that all unfolded. And it was because of the ownership of that patient. And it wasn't handed over. He followed what he was supposed to do, but he also troubleshot what he was supposed to do. And that's kind of my point, is we at the Grey Nuns have involved frontline staff. We had a charge nurse meeting. I presented our QuiCR learnings to the charge nurses. 3 of them had to leave early. They went upstairs and they let a patient right into the shift. So it's that communication, it's that involvement of frontline and supporting the frontline through those decision points. So this is our October mean and median times for both the Grey Nuns and the U. Our median is 29 at the Grey Nuns for October. U is 35 minutes, and we're extraordinarily proud of those times. We've come a long way, and we'll even go farther, but we're really, really happy. Next steps, we need to do some discussions with admitting about bedside registration, and how do we expedite that admission process in regards to the chart. We've actually liticked several times at the Grey Nuns without even having a chart. We had a case not too long ago where the patient was from out of country and they were having a really tough time in admitting, linking up a chart. So in absence of a chart, we went ahead, pulled off the lab work, hand wrote the requisition. I know my lab colleagues want to have a stroke when I talk about that, but we did it, and sent the patient down to CT, analytic down in CT without the chart. We need to discuss with EMS, such as refining the pre-hospital notification. What we'd really like to see is the ability to have a patient identifier attached to that pre-hospital notification, and then we can pre-make the chart, which makes everything even more streamlined. And we'd like to collaborate with EMS to standardize the process. So what they're currently doing at the Grey Nuns is taking the patient direct down to CT, and we'd like to see them doing the same thing at the U. And that's my presentation. Thank you so much.